Welcome to Section 3, on performing basic life support and first aid procedures. In this section we will be discussing first aid procedures. If you ever find yourself in an emergency situation, where someone is ill or injured, then you will need to perform a primary survey. On arrival, first aiders should follow the procedure below. Take charge of the situation. Call to attract the attention of bystanders. Assess hazards by establishing cause of accidents, and secondary causes of the result of the accident. Identify yourself as a first aider and offer help. Before attending to the patient of any emergency, you must first survey the scene, to ensure your safety. If you as the first aider is injured or killed, you cannot render assistance. If you as the first aider is contaminated with infected blood, you can die of a disease. No injured person should be moved if his or her life is not in danger. If a person is not breathing and has no pulse, his or her life is in danger. Life-threatening situations exist, where there is significant risk of loss of life, for example, people that are trapped in a burning car or a child that is drowning. All hazards, influencing the safety of the first aider and injured, must be removed before assistance can be rendered. Ensure that you have the necessary protective equipment with you, for example latex surgical gloves and a barrier device. Check the patient. After determining that the scene is safe, do a primary examination. This refers to a quick assessment to life-threatening conditions. Responses. Determine the level of consciousness of the injured, by looking and listening. Look for body movement, and listen for noises made by the injured. The initial primary survey is a quick way to assess patients. It can easily be remembered by the letters HHHCAB. The first H stands for hazards. The second height stands for hello. The third H stands for help. C is for circulation. This is when we check for a pulse and excessive arterial bleeding. A is for airway. We check if the patient's airway is open, maintained, and protected. B is for breathing. We check if the patient is breathing normally. If the patient is not breathing or gasping, and the patient does not have a pulse, start with CPR immediately. If the patient is breathing abnormally and has a pulse, start with rescue breaths. If the patient is breathing normally and has a pulse, check for the following. Circulation. Look for obvious open fractures and burns, and treat these injuries first. Airway. Do a log roll or recovery position, to protect and maintain the patient's airway. If you ever find yourself in an emergency situation, then all you need to remember is HHHCAB, and you will be able to systematically assess your patient, and decide what to do.
Right, I arrive at my scene, I check what happened, I gather information from the bystanders, what happened, when did it happen, how did it happen. If it is trauma, I ask the patient to lie still. In this case, this is a non-trauma or a medical patient. So I approach my patient. Good day, ma'am, my name is Nikki, I'm first aid qualified. What is your name? Matapelo. Can you tell me what happened? You're not feeling well. Right. Hazards and hello has been done. So I ask my bystanders, sir, can you please phone 112 for me? Tell them I've got an adult female that is not feeling well. Give them the location and report back to me. Do you understand?
Yes, I do.
Please bring me a first aid kit as well.
I will.
Right. Matapelo, you're obviously speaking to me. Your airway is open. Can you take a nice deep breath in for me? And out. And out. Any pain on that?
No.
Right. So the airway is open, the breathing is checked, and then we're just going to quickly check for any life-threatening bleeding around the patient.
Now that you know the patient's basic observations and condition, you have more time to thoroughly examine a conscious patient, by systematically looking and feeling. The secondary survey is the practical management of injuries, in the order of priority, as detected or medical conditions. Conduct a head-to-toe secondary examination. Remember to be sensitive to the age, sex, and culture of the patient. Start the secondary examination, by informing the patient of what you are going to do, and the reason for doing the examination. Listen carefully to what the patient tells you, while doing your examination. Check for any abnormal fluids, numbness or tingling, and abnormal sounds. Also remember to check for medical alert bracelets or necklaces. Pay attention to the history of the patient and incident. The acronym SAMPLE can be used for this. S stands for signs and symptoms. Which signs do you see, and which symptoms does the patient have? A is for allergies. What is the patient allergic to? Is the patient struggling to breathe because of something they ate? M is for medication. Which medication is the patient currently taking? Is the patient feeling ill because he forgot to take his medication this morning? P is for past illnesses. Does the patient have any chronic conditions, like high blood pressure or diabetes? L is for the last time the patient ate or drank. Is the patient maybe feeling dizzy because they have not eaten today? E is for event. What happened, where and when did it happen? A good tool to remember the signs of injury is dots, when you look and feel during your secondary examination. D stands for deformity. Do you see any deformities on the body? If you are unsure, compare the two sides of the body with each other. O is for open wounds. Look for any open wounds or bleeding. T is for tenderness. The patient will tell you if the location is tender to touch. S is for swelling. Look for any swelling on bruising on the body. After immediate threats to life have been removed, a secondary examination is necessary. This is a systematic examination starting from the head down to the lower limbs, as follows. Temperature. Feel the forehead and the back of the neck, to see if the skin temperature is much warmer or cooler than that of your hand. Pulse. Check the pulse, noting its rate, strength, and rhythm. Breathing. Note the rate, rhythm and depth, and smell the breath for distinctive odors of chemicals, or acetone. Eyes. Note if the pupils are fully dilated, constricted, or of unequal size, and then check for reaction to light. Ears and nose. Look for any blood and other fluid discharge that may indicate skull injuries. Mouth. Check the mouth for fluids or vomitus that might affect breathing. Also check for false teeth if the casualty is unconscious. Skin. Note the color, the amount of perspiration, and the temperature. Skull. Check for bruises, bumps or bleeding that may indicate head injuries. Neck. Check the neck gently. If there is pain or a deformity, suspect a fracture of the spine at the neck. Spine. Feel along the center line of the back for irregularities. If there is bleeding, you feel an area that is warm and wet, or if there is tenderness and pain, suspect a fracture of the spine. Chest area. Look for wounds, and note any unnatural movement of the chest. Gently feel the ribs with the fingertips for irregularities or, if the casualty is conscious, ask him to take a deep breath and cough. Pain and tenderness indicate a possible fracture of the ribs or sternum. Abdominal area. Look for wounds and bleeding, and ask the casualty to pull in and push out their abdomen. Suspect internal injuries if this causes pain. Pelvic area. Gently feel on either side of the hips for signs of tenderness or irregularities that might indicate a fracture of the pelvis or dislocation of the hip. Lower and upper limbs. Check the limbs for irregularities in the long bones or joints. To assess for nerve injury and loss of power, ask the casualty if he is feeling in the fingers and toes, and if he can move his limbs. After checking the patient, call the emergency services, and give them a description of the emergency, as well as the location of the scene. After calling the emergency services, provide appropriate care, based on your primary survey of the patient, until emergency services or other advanced medical personnel arrives and takes over. The following acronyms can be used when handing a patient over to a person with a higher medical qualification. These acronyms help us to remember which information is important. For a medical patient, remember, NIS. N stands for the nature of the illness. I stand for which illness does the patient have. S stands for signs you can see, and symptoms that the patient may have. T is for which treatment did you provide to the patient. T is for the time the incident happened. For a trauma patient, remember, MIT. M stands for the mechanism of injury. How and what injured the patient. I stands for injuries. What injuries did the patient obtain? S stands for the signs you can see and the symptoms the patient is feeling. T stands for the treatment that you have provided to the patient. T stands for the time the incident or accident happened.
We are going to be performing the secondary survey now. Now, hazards and health, circulation, airway and breathing has been done. We are going to be looking now for any other injuries using dots, deformities, open wounds, tenderness or swelling. Now I want to reiterate, if possible, if I have a female patient, let it be a female that does the secondary survey. If it's a male patient, preferably a male first aider. Right, when we do the secondary survey, we do a head to toe. So we start at the head. First thing that we do, always close your fingers and feel for any dots. Feel on top of the head and feel around the eyes. If the patient is awake, ask them to close their eyes and then to open it again, checking for the pupil reactions. From there, we check the nose and we check inside the nose if there's any blood. From there, we can check inside the ears and at the back of the ears, just to see if there's any fluids or any bruising behind the ears. From there, we feel the upper and lower jaw. We can ask the patient if she's awake to open her mouth, check if all the teeth are in place and not broken, and also check for any blood or vomit inside the mouth. You can relax, thank you very much. From there, we go down to the neck. We look for any distended neck veins or a deviated trachea. Or you can even look for a medical alert necklace. From there, we go to the shoulders. Remember, closed fingers. First things that we feel is the collarbones. Just press slightly down, not too hard. You will feel movement if there's a problem. Okay. From there, we feel if the shoulder is in place. Look at your patient's response. If there's any pain, she will frown or tell you. We go down to the upper arm. Just feel slightly, putting your hands in this position and just squeezing towards each other slightly. Please don't press too hard, because if there's a fracture, you might make it worse. If you don't suspect any injuries on the elbow, you can ask the patient if they can bend the elbow, and then also the lower arm. If you get to the lower arm, feel if there's a pulse present. We check the hand, each and every finger. Okay. Also remember to check inside the hand and to check capillary refill. Okay. What we do on the one side, we do on the other side. Now, if your patient is awake, Matapelo, can you take a deep breath in for me? Can you breathe out? Any pain on that?
No.
Okay. If the patient does say that there's any pain, we expose. Remember to try and keep it as private as possible. And we check for any injuries on the chest. You can also feel by just placing your hands inward and pressing slightly inwards to feel if there's any broken bones. And you must feel the sternum. Now please never place your hand like this on a female. Your hands must always show downwards. Right. Then we go down to the abdomen. You take your strongest hand and you put it at the bottom and your weakest hand on top. And you just gently squeeze in and you move in 4 quadrants of the stomach or abdomen, looking for any response from the patient. At the pelvis, all we do is just place our hands in the side and press towards each other, just to feel if there's any instability. Please do not press on top of the hips. From there, we go to the upper legs and we do the same as with the arms, gently squeezing towards each other. At the knee, you will feel the knee. This is a bone that moves. Okay. If it is stuck, it usually means that there is a problem. We go down to the lower knee, with the lower leg. Right? You can remove the shoes, it's not a problem. And then we can feel if the toes are moving. Matapelo, can you move your toes for me? Very good. Any pain on that?
No.
Okay. If I like the bottom of your shoe, can you feel that?
Yes.
Very good. And if you remove the shoe, remember to check for capillary refill. What you do on the one side, you do on the other side.
Measuring a person's level of consciousness. Changes in the level of consciousness of a person who may have sustained an injury to the head are an important sign of the way the brain is functioning. The scale used to measure this is commonly called AFPU. See the following page for details. The head-to-toe survey of the injured patient. Management. Life over limb. Control bleeding, cool burn wounds, immobilize fractures. The head and neck. Control bleeding and cover wounds. The chest. Control bleeding and cover wounds. Close any sucking open chest wound, which will be discussed later. Stabilize impaled objects and cover wounds. The stomach. Control bleeding and cover wounds. The extremities. Control bleeding with direct or indirect pressure and cover wounds. Position the patient. Cavities gets preference over extremities. If a cavity is injured, position the patient onto injured side. If extremities are injured, position onto uninjured side. Reassure and maintain body temperature. Monitor the vital signs every 5 to 10 minutes until EMS takes over. Injuries. There are 3 injuries that take precedence over the rest, and emergency services should be called if the patient has sustained injuries to the head, neck or back. The patient is having trouble breathing. The patient is unable to move or use the injured body part without experiencing pain. These require special and careful attention. Information needed to determine the casualties, injuries or illnesses grouped under 3 headings and defined as follows. History. Events leading to emergency situations, accidents or violence. Signs. Conditions you can see that indicate disease or injury, for example, body temperature, pulse, breathing patterns commonly named as the vital signs. Symptoms. The sensation the person feels as a result of the injury or illness, i.e., cold, pain, nausea, numbness, etc. Monitoring the patient. Vital signs and symptoms. It is especially important to monitor the patient, as the condition of the patient can change very rapidly. It is often particularly useful to provide the paramedics with a record of the patient's condition. It is for these reasons that the following signs and symptoms be monitored regularly, approximately every 5 minutes. Level of consciousness, also known as AFPU. The breathing rate. Circulation, especially pulse rate. Skin color. And skin temperature. Monitor casualty and treat according to vital signs and condition. There are different signs that a first aider should be aware of. These signs are stressed in order to monitor the condition of the injured person. The pupils. Shine a flashlight or headlamp into the injured person's eyes. Note whether the pupils contract symmetrically when exposed to the light. If the pupils are unequal in size, then it may be a sign that the person is using drugs. Look out for these warning signs because you can save a life. Blood circulation or capillary refill. This is usually done on the nail beds of a patient. This can be done on the fingers or toes. If the white area does not turn pink within 2 seconds, this may indicate that oxygen-rich blood is not circulating properly. Blood will return to a healthy person's capillaries in less than 2 seconds, changing the color of the pressed spot from white to pink. Checking for a pulse. The pulse is checked with the index and middle fingertips by gently pushing down onto an artery. There are 3 ways in which a pulse can be measured, namely, carotid pulse. This being the preferred method for checking adults and children. The pulse is checked on the carotid artery in the patient's neck between the neck muscle and the trachea, also known as the air pipe. Radial pulse. This is checked on the palm side of the wrist, above the thumb. Brachial pulse. This is the most reliable and most easily found in infant, located in the inside of upper arm. Femoral pulse. Located in the thigh, halfway between the pubic symphysis and anterior superior iliac spine. Popliteal pulse. Above the knee in the popliteal nasal, found by holding the bent knee. The patient bends the knee at approximately 124 degrees, and the physician holds it in both hands to find the popliteal artery in the pit behind the knee. Dorsalis pedis pulse. Located on top of the foot. Temporal pulse. Located on the temple directly in front of the ear. Never use your thumb to feel for a pulse, as the thumb has a pulse of its own. Do not feel or compress both carotid arteries at the same time. This could affect blood supply to the brain and cause severe damage. Feel for the pulse for 10 seconds. If the pulse is present but the patient is still not breathing, continue artificial respiration at the rate of 1 ventilation every 6 seconds. This is also known as rescue breathing. If there is no pulse, begin CPR immediately. Important to remember that the pulse rate is respective of the age of the patient. Adults have a pulse rate of 60 to 100 beats per minute. Children have a pulse rate of 100 to 120 beats per minute. Infant up to 1 year a pulse rate of 110 to 160 beats per minute. Skin appearance. The appearance of the skin can be a good indicator of the patient's condition. Check color, condition, and temperature of the skin. The color of the skin. Check the color of skin in the mouth and lips. Red, pink, pale or blue. Checking the lining of the mouth and lips allows a quick assessment of patients from all ethnic backgrounds. The temperature of the skin. Is the skin warm or cool to touch? The skin condition. Is the skin dry or wet? Breathing or respiration. The respiratory rate is the number of breaths a person takes per minute. The rate is usually measured when a person is at rest and involves counting the number of breaths for 1 minute. This is often done by counting how many times the chest rises. To save time, this can be done over 30 seconds and then the result doubled. However, this is a less accurate method. Respiratory rates may increase with fever, illness, and with other medical conditions. For example, an asthma attack is likely to significantly increase the respiratory rate. When checking respiratory rate, it is important to also note whether a person has any difficulty breathing, or if there are any sounds during breathing, for example, a wheeze. Normal respiratory rates for an adult person at rest range from 12 to 20 breaths per minute. Children have faster respiratory rates. An effective way to take a respiratory rate is to combine it with taking the pulse rate. Explain to the person that you are going to take their pulse for a minute. Count the pulse for the first 30 seconds, and then count the respiratory rate for the second 30 seconds. This avoids the person changing their breathing pattern subconsciously. The breathing rates are as follows. Adults, 12 to 20 breaths a minute. Children, 5 to 12 years, 20 to 25 breaths a minute. Children, 2 to 5 years, 25 to 30 breaths a minute. Children, 1 to 2 years, 25 to 35 breaths a minute. Infant up to 1 year, 30 to 40 breaths a minute. Head, spine, and neck injuries. A patient with a head, neck, and spinal injury should never be moved if his or her life is not in danger. The life is only in danger if the patient is not breathing and has no pulse. The first aider must understand the mechanism of the injury, get the full story or history from bystanders, and if the casualty is conscious, allow him or her to explain the course of events. Study the emergency scene for clues to establish the nature of the injuries. Common symptoms. The following symptoms could be present. Changes in consciousness. Vision and breathing problems. Nausea and vomiting. Inability to move a body part. Steady headache. Tingling or loss of sensation in hands, fingers, feet, or toes. Blood in the ears or nose. Seizures. Severe pain, pressure or bleeding in the head, neck or back. Bruising of the head. And loss of balance. Treatment. When the patient must be moved, it has to be done as a unit, with the spine in a straight line. 4 first aiders, or helpers, kneel on one side of the patient that has been immobilized. 1 first aider, the leader, holds the head of the injured in his hands, while the next places his or her hands on the shoulder and side of the chest. The next first aider places his or her hands on the hip and the outer part of the upper leg, while the last first aider controls the feet. The first aider at the head is in charge and on his or her command, and on the count of 3 moves the patient as a unit onto his or her side. A stretcher is placed under the patient, and on the count of 3, from the leader, rolled back onto the stretcher. These are considered critical injuries, and take precedence over the rest, and emergency services should be called. Do not move the patient, unless you are positive there are no spinal injuries. You must always prevent any further damage to the spine, and never move your casualty if it is not necessary. Spinal nerves, if pinched, can cause paralysis. Conditions when casualty can be moved. When casualty is not breathing and has no pulse. When conditions dictate that the casualty has to be moved, for example, if the car is on fire. Procedure when transporting. Make sure the patient is fully immobilized and prevent further injury. Move the patient as a unit, with the head, neck and shoulders aligned. Check the patient's airway while transporting. See that all equipment stays fastened.
Okay, we're going to be demonstrating the lock roll. Sydney, you are at the head. Matapelo, you are above the hip and below the knee. And I'm going to be at the shoulder and at the hips. Now what we do is we crisscross the patient's arm. There we go. Now, the reason why we're doing the lock roll is for head, neck, and spinal injuries to protect the airway. The person at the head is the person in charge of the lock roll.
First aiders, we lock roll in 3. 1, 2, 3. First aiders, lock roll back. 1, 2, 3.
Head injuries. Injuries to the head are always regarded as serious because they can inflict damage to the brain and spinal cord as well as damaging the bone and soft tissue. As a result, head injuries can be devastating to the patient. Head injuries can be invisible to the eye. In many instances, a patient who appeared unaffected after an incident suddenly collapses, with life-threatening symptoms some hours later. This may be due to the sudden movement of the head forward and backward, on impact, which may cause a small bleed in the brain, that eventually increases and applies excessive pressure on the brain tissue. Such injuries can easily mislead the first aid provider by not exhibiting the expected signs and symptoms immediately after an incident. As a first aid provider, you should always take head injuries seriously. Always check the patient's response and whether they have any alteration of consciousness. Look at the history of the incident and the mechanism of injury. If, in your opinion, the patient's conscious state is altered, or the incident had the potential to cause serious injury, assume the worst and treat as a serious head injury. Understand the mechanism of the injury. Get the full story or history from bystanders, and if the casualty is conscious, allow him or her to explain the course of events. Study the emergency scene for clues to establish the nature of the injuries. Head injuries can be either open, for example a head injury with an associated head wound, or closed with no obvious sign of injury. Symptoms and signs: bruising and or redness, dazed or confused reactions, patient may vomit, unusually slow pulse rate, pupils dilate irregularity, visible or obvious fracture, blood in or fluid coming from nose or ears, and unconsciousness. Treatment for head injuries: if a head injury is determined or suspected, maintain open airway. Suspect cervical, also known as a neck injury. Position your patient with head lifted if head injury. Do not put anything under the head. Make sure that the injured side of the head faces the ground so that fluid can drain. Control any bleeding. Dress any wounds. And treat for shock. What not to do: leave the victim alone, especially when they is sleeping. Wake them up every 3 to 4 hours and have them answer simple questions to make sure there is no brain injury, such as a concussion. When to seek medical attention: call the medical emergency services if the victim exhibits seizures, dizziness, vomiting, nausea, or obvious changes in behavior. Unconsciousness. It is important to remember that the brain is the control center of the body and controls the working actions and functions of the body. If a patient is unconscious but breathing normally, then you should place them into the recovery position to protect their airway. It is best to place your patient in a stable, comfortable, and safe position. The recovery position involves rolling the patient onto their side with their head tilted back. By doing this, the tongue is kept clear of the airway, and any vomit is able to drain and not obstruct the patient's airway. What about injuries? At this stage, do not worry too much about the patient's injuries. Your main priority is to protect the airway, assist with breathing, and control life-threatening bleeding. Once the person has been placed in the recovery position, you can start assessing and treating any other injuries which you have found. The advantages of the recovery position: the airway remains open, and tongue cannot block it. Gravitational drainage can take place, for example, vomit will be expelled. The pulse, especially the carotid, can easily be monitored. And it is a safe and comfortable position for your patient. Treatment: provide and maintain an open airway. Treat the cause. Place in recovery position. Treat for shock. Seek medical help. And monitor vital signs every 2 minutes. Fainting. Fainting is a brief and sudden loss of consciousness, normally due to a reduction in the blood flow to the brain. Normally, a faint results in a person falling to the floor. The brain requires a constant supply of oxygen and nutrients. This supply is provided by the blood. There are numerous things that can interrupt this supply. For example, blood tends to pool in the legs during periods of inactivity, for example, standing or sitting for long periods of time. If you suddenly stand up, the heart has to work harder to pump this blood upwards, against gravity. This can cause a head rush in some people, with a feeling of dizziness. However, in other people, this interruption in the blood supply to the brain causes them to lose consciousness, called a faint. Generally, once a person has fainted, and fallen to the floor, they regain consciousness very quickly. This is because when lying down, the heart finds it easier to pump blood to the brain, as it is not working against gravity. There are some telltale signs that someone is going to faint. They may go very pale white, and look unsteady on their feet. Also, they may complain of feeling lightheaded or funny. Treatment for a faint. If someone complains of feeling faint, you should lie them down, on the floor with their feet elevated until they feel better. This is to prevent any injuries occurring if they do fall. If someone has fainted, you should raise their legs, to improve the blood supply to the brain. If they have fallen, check for any injuries, such as fractures, or head injuries. Once they recover, help them sit up gradually. Do not let the patient stand up straight away, as they may just faint again. If the patient does not wake up, check to see if they are breathing. If they are, roll them onto their side in the recovery position, and call an ambulance. If the patient recovers fully and has not suffered any injuries, there is no need to call an ambulance. If they are not sure what caused the faint, or have not fainting before, then it is advisable for them to seek medical attention. Rib fracture. Ribs are pretty hard to break. They are surrounded by strong muscles, and usually can take a lot of abuse, before they crack. The elderly can get broken ribs easier than younger adults. Kids have more flexible bones. Most broken ribs, including children, come from vehicle accidents, but they are also common from falling off horses, sports injuries, and falls. Most of the time, the broken rib is only broken in one place, and is an incomplete fracture, meaning not all the way through the bone. Completely broken ribs may, or may not move out of place. If they do move, they are called displaced rib fractures, and are more likely to puncture lungs, or damage other tissues and organs. Ribs that stay in place, usually ribs that are not completely broken in half, are called non-displaced rib fractures. Broken rib complications. The most common complication of broken ribs is not being able to take a deep breath, because it hurts. If you do not breathe deep enough, mucus and moisture can build up in the lungs, and lead to an infection such as pneumonia. Displaced rib fractures can damage other tissues, or organs, and sometimes lead to collapsed lungs, or internal bleeding. Treatment. Do not wrap tight bandages around the chest. Support the chest with a pillow. Manage shock and monitor vital signs. A change in breathing can indicate the development of a pneumothorax, also known as a collapsed lung. Bone injuries or fractures. Fractures are classified as open and closed fractures. A fracture is when there is movement of the bone, where there should be no movement. There are two types of bone injuries or fractures, namely, open fractures. Broken bone tears through the skin, causing an open wound. Closed fractures. Skin is not broken. Common symptoms. The following symptoms could be present. Pain or tenderness at place of fracture. Inability to use limb. Swollen. Discolored. Irregular line of the bone, under the skin, known as a deformity. Shock. Crepitus, the grating noise as the broken end of the bone, rubbing against each other. Sometimes shortened. The following rules apply to splinting a fracture. Secure above as well as below the fracture. Secure above and below a joint. The splint that is being used must be hard and long enough to support the fractured bone. Always support the long bones. Splint the fracture in the position you find it. Always check for pulses, capillary refill, comfort, and movement. Always feel for a pulse below the injured part. When no pulse is detected, seek medical assistance immediately. Do not try to move a patient with a severely broken bones, unless it is absolutely necessary. Calling emergency services is the best course of action in this case. However, if you must move the patient, you must immobilize the injured body part. One way is to splint it, but only do this if it can be done without hurting the patient, and always attempt to splint the part in the position you found it. Splint the injured area. You may use another body part, like an injured leg to an uninjured one, or an injured arm to a chest. This is called an anatomic splint. Make a soft splint from folded blankets or towels, or use a triangular bandage to make a sling. A sling is another type of a soft splint, which is used to support an injured arm, wrist, or hand. Use folded magazines or newspapers, cardboard, or metal strips, to support the injured body part with a rigid splint. Use several folded triangular bandages to secure the injured body part to the splinting material, tying them securely, but not too tight. Raise the injured part, and prevent the patient from getting chilled or overheated. Pelvic fracture. The pelvis is surrounded by strong muscles, and you will seldom find open fractures. Direct or indirect impact can cause pelvic fracture. Occasionally, bone fragments can lacerate the rectum, vagina, bladder, blood vessels, or uterus. As a result, 40% of the patients will develop hypovolemic shock. Signs and symptoms: severe pain in the pelvic area, and with movement of the legs. Tenderness on firm compression, and palpitation. Treatment: stabilize pelvis, with broad bandage. Place a rolled blanket between the legs of the patient, and tie the legs together. Turn patient, as a unit onto a full trauma board. Monitor vital signs. Manage shock.
Okay, here we're going to demonstrate how to secure the pelvis if there's a pelvic fracture. Demonstrate what we're going to do to the patient. You're going to need, if you want to use it, a splint, a sheet, and plus minus 5 triangular bandages. So what we do, just push the sheet in underneath the patient. Alright, and then we just zigzag this underneath the patient. There we go. Make sure that it's more or less 50-50.
Yes.
There we go. We bring the ends together. And we twist. Secure on top. And then we wet the knot. This is just to make sure that your knot doesn't slip. And then we pull nice and tight. And we tie it off again. Alright. The triangular bandages. Sydney, can I ask you to open one for me so long, please? Matapelo, extra bystander. Here we go. Keep it as a broad bandage. Okay, so all we do is we just open them nicely. Okay, they folded it like this. So you need to quickly fold broad bandages. There we go. Okay. So the rule says above a joint. There we go. Now here comes the trick. Usually when we tie on the legs, because there's a fracture, just check your capillary refill, or you can check for pulses on the feet if they are present. So, tie above the knee joint, we tie below the knee joint, okay. Remember to check your pulses and your capillary refill. Okay, and then we have another joint here at the bottom, which we can use here at the ankles. There we go. Okay, but now this one, because it's a long bone, we are also going to support the long bone. So what I suggest is just to pull this one into position first. There we go. And then may I have another triangular bandage, please? Oops, sorry. There we go. Ankles. And you can it off like this. Or you can add another bandage and tie the feet properly nice together as well.
Sprains. It happens that a person stretches a muscle, ligament, or tendon beyond its capacity. The tissue under the skin has been damaged, and internal bleeding exists. A closed wound occurs under the skin. This is called a sprain. Common symptoms. The following symptoms could be present. Swelling at the joint. Sprains occur when the ligaments surrounding a joint are pulled beyond their normal range. Sprains are often accompanied by bruising and swelling. Treatment. A cold compress, for example an ice pack covered in a cloth, must be put onto the injured part to control blood circulation. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Dislocations. A dislocation is the displacement of bone ends at a joint. A joint is stabilized with ligaments and muscles, which can easily be torn during excessive movement. The joint can or cannot be deformed, and may be mistaken for a fracture. Dislocations involve mostly the shoulder, elbow, finger, jaw, wrist, knee, or hip. Common symptoms. Pain and pressure at the joint. Loss of movement and possible deformity, swelling and discoloring. Treatment. Never attempt to replace or reposition a dislocated joint. Improvise support and comfort using padding or a pillow. Adhere to the basic principles of immobilization. Burns. Burns are classified in the seriousness, degrees, and types burns. Degrees of burns. First degree or superficial burn. The surface of the skin has been burned and has changed color, for example, sunburns. This type of burn usually heals in 5 to 6 days, without any permanent scarring. Common symptoms. The following symptoms would be present. No blisters. Skin has just been warmed. Skin is red and dry. Painful. Burned area may also swell. Treatment. This type of burn is treated with cold water running over the surface of the skin for at least 20 minutes. No further treatment is necessary. Second degree burn, or partial thickness burn. A second degree burn involves the top layers of skin. The dermis of the skin has been burned and has changed color, and blisters have appeared. Common symptoms. The following symptoms could be present. The skin is red. Blisters that may open and weave clear fluid, giving the skin a wet appearance. The area may also appear mottled. The burn is usually painful and often swells. Treatment. This type of burn is also treated with cold water running over the surface of the skin for at least 20 minutes. The burn must be covered with sterile bandages. And the blister should not be broken. Seek medical assistance. With this type of burn. Treat for shock. Do not use fluffy dressings on this burn wound. This type of burn usually heals in 3 to 4 weeks, and scarring may occur. Third degree burn or full thickness burn. A third degree burn destroys all layers of skin and any or all of the underlying structures, including fat, muscles, bones, and nerves. This burn is critical and requires immediate medical attention. Common symptoms. The burn appears brown or black, with the tissues underneath sometimes appearing white. Blisters appear around the burnt area. Extremely painful, or relatively painless if the burn destroys the nerve endings. Treatment. All clothing or material sticking to the skin on the burn wound should never be removed. Clothing and material sticking to the wound should rather be cut loose and the burn covered with a wet cloth or clean piece of plastic over the burned area. The burn is then covered with sterile dressings and cold running water poured over the dressing to cool down the burn. Seek medical help. Treat for shock. Do not use fluffy dressing on this burn wound. Types of burns. These are examples of causes of burns. Scalds are usually caused by steam, hot foods, boiling cooking oil and water, etc. Dry burns are usually caused by a fire, the sun, cigarette burn, etc. Chemical burns are usually caused by chemicals. Where a chemical reacts with water, it should be removed first before being cooled with water. Electrical burns can have 2 burns, and can have effects on the heart. Thus ensure to monitor circulation and breathing. Bleeding. Bleeding is categorized in two categories, namely external bleeding and internal bleeding. Whenever bleeding must be stopped, surgical gloves need to be worn for protection. The amount of blood in an adult's body is determined by his size and weight. An approved method to determine the amount of blood in a person's body is by dividing his body weight by 10. The answer indicates more or less the amount of blood in that person's body in liters. For example, 76 kg divided by 10 equals 6 liters. The person's life is in serious danger when quarter of the blood volume is lost. External bleeding. Note: bleeding must be controlled so that the body can stop the bleeding. Bandages and dressings only minimize bleeding and prevent infection. External bleeding is caused by wounds and is classified as arterial bleeding. The artery transporting blood from the heart is damaged. The blood is bright red in color and is lost from the body in a squirting action. The best way to stop such bleeding is by applying direct pressure on a pressure point between the injury and the heart with the hand. A pressure pad and bandage may also be used. Venous bleeding. The vein transporting the blood back to the heart is damaged. The blood is dark red in color and is lost in a flowing out action from the body. The best way to stop such bleeding is by applying direct pressure to the wound with clean cloths and bandages. Capillary bleeding. Blood seeps from a superficial wound and is bright red in color. The best way to stop such bleeding is by applying direct pressure onto the wound with clean cloths and bandages. Treatment for external bleeding. If cavities are involved, apply wound dressing with moderate pressure. Localize the bleeding, for example, position the patient. Treat for shock. If extremities are involved, direct pressure. Elevate if possible. Pressure point. Treat for shock. In most cases, the average person may find they are not prepared and unable to administer the best first aid possible, because they lack the knowledge of various types of dressing and bandage materials available, or the proper use of these important first aid items. A dressing is used to cover a wound, to assist with control of further bleeding, and prevention of further contamination. There are 3 types of dressings that should be part of any first aid kit, namely adhesive, pressure, and gauze dressings. The purpose of a dressing is to control bleeding, prevent infection, absorb blood and wound drainage, and to protect the wound from further injury. Types of dressings include pads, sterile eye pads, sterile gauze pads, sterile non-adherent pads, and burn dressings. A burn dressing is a sterile pad soaked in a cooling gel. Always make sure that the pads you are using are sterile, or as clean as possible, as they are applied directly to the wound. The dressing should also be absorbent, to soak up body fluids such as blood or any discharge. The dressing must be soft and compressible, so pressure can be distributed over the wound. Always make sure the dressing is non-fluffy, so the material will not stick to the wound. Please do not use cotton wool directly on a wound. There are different types of bandages. Their sterility is not necessary, as they are used to secure a dressing. They should, however, be as clean as possible. Gauze roller bandages are absorbent, breathable, and often elastic. Elastic bandages are used for sprains, and as pressure bandages. Adhesive, elastic roller bandages are highly effective pressure bandages and durable, waterproof bandaging. Triangular bandages are used as slings, tourniquets, to tie splints, and many other uses. The most used type of bandage is the gauze bandage. It is a simple woven strip of material, which can come in any number of widths and lengths. A gauze bandage can be used for any bandage application, including holding a dressing in place. A triangular bandage is a piece of cloth, cut into a right-angled triangle. This is felt by many trainers to be the most versatile of the bandages available, as it can be used fully unrolled as a sling, folded as a normal bandage, or for specialist bandages such as on the head. Sometimes dressings and bandages are combined, in which case they must be sterile. Adhesive bandages like band-aids and sticking plasters are of the most used items in a first aid kit. Examples are straight adhesive bandages and butterfly or knuckle bandages. The main types of bandages are triangular and roller bandages. They are used to secure the dressing and assist in control of bleeding. Provide support to a limb or joint. Hold splints in place and immobilize parts of the body. If a bandage is applied, it should cover the whole dressing, and do not remove the bandage once it is in place. If it becomes saturated with blood, apply another one on top, so that clotting that has already taken place will not be disturbed. There should always be a pulse distal to the side of the bandage. Where possible, keep the nail beds uncovered, to enable detection of inadequate distal circulation. Should signs of inadequate distal circulation be visible, as observed from skin temperature and color, loosen the bandage, and reapply. An occlusive dressing is an airtight dressing that can be used to treat a sucking chest wound, in which air is sucked into the chest cavity, collapsing the lung. This is known as a pneumothorax. For this use, an occlusive dressing should be taped on 3 sides only, to create a one-way valve. Petroleum gauze, also used as non-adherent dressing, can be used as an occlusive dressing, as well as half of any gauze wrapper, since the inside is sterile and airtight.
Internal bleeding. Internal bleeding can usually not be seen, and a patient can bleed themselves to death, without spilling one drop of blood. Internal bleeding can however be seen when blood flows from inside of the ear, from the lungs and abdomen, intestines, and bladder. The patient will be cold, clammy, very weak, pale, and dizzy, have a rapid pulse, breathe rapidly, and will complain of pain in the injured area. The patient must be laid down, feet elevated not more than 20 centimeters, and are covered with a blanket. Bleeding from inside the ear should never be stopped. Look out for or find out. History of injury that caused internal bleeding. History of a medical condition, for example, ulcer, which may cause internal bleeding. Pain and tenderness around the affected area. Swelling and/or bruises. Signs and symptoms of shock. Blood may appear from one of the body's orifices. Blood-speckled froth at the mouth. Treatment for internal bleeding. Cavities. Localize the bleeding, for example, position the patient. Treat for shock. Extremities. Apply ice indirectly. Elevate if possible. Treat for shock. Wounds. Wounds are classified as open and closed wounds. Treatment of the casualty and aseptic principles. Aseptic means preventing infection. First aiders must comply with the aseptic principles and only use sterile items. Sterile objects become unsterile when touched by unsterile objects. The skin cannot be sterilized and is unsterile. If the wound is not deep and gapes slightly, the first aider may find that he or she only needs to hold the wound edges together, dress, and bandage the wound. At times, however, it may be difficult for the first aider to decide whether a wound needs medical care. The first aider may ask the question: does this wound need suturing by a medical practitioner? An open wound condition requires medical treatment when the following occur: blood spurting from a wound, bleeding that persists despite all efforts to control it, an incised wound deeper than the outer layer of the skin, crushed nerve, tendon, or muscle, skin broken, bite human or animal, foreign object embedded deep in the tissue, foreign matter in a wound, not possible to remove by washing. Any other open wound where there is doubt about what to do.
Open wounds. Open wounds occur where the skin's tissue has been damaged or torn. External bleeding takes place, and the bleeding has to be stopped, according to the treatment for external bleeding. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Foreign objects may be stuck in the patient's body, and should never be removed but rather stabilized, with a ring pad or stabilizing bandage. Examples of open wounds are incisions, lacerations, punctures, animal bites, contusions, abrasions, bruises, and ballistic wounds. Incisions. Incisions, commonly called cuts, are wounds made by sharp cutting instruments, such as knives, razors, and broken glass. Incisions tend to bleed freely, because the blood vessels are cut cleanly, and without ragged edges. There is little damage to the surrounding tissues. Of all classes of wounds, incisions are the least likely to become infected, since the free flow of blood washes out many of the microorganisms or germs that cause infection. Lacerations. These wounds are torn, rather than cut. They have ragged, irregular edges, and masses of torn tissue underneath. These wounds are usually made by blunt objects. A wound made by a dull knife, for instance, is more likely to be a laceration than an incision. Bomb fragments often cause lacerations. Many of the wounds caused by accidents with machinery are lacerations. They are often complicated by crushing of the tissues as well. Lacerations are frequently contaminated with dirt, grease, or other material that is ground into the tissue. They are therefore highly likely to become infected. Punctures. Punctures are caused by objects that penetrate into the tissues, while leaving a small surface opening. Wounds made by nails, needles, wire, and bullets are usually punctures. As a rule, small puncture wounds do not bleed freely. However, large puncture wounds may cause severe internal bleeding. The possibility of infection is great in all puncture wounds, especially if the penetrating object has tetanus bacteria on it. To prevent anaerobic infections, primary closures are not made in the case of puncture wounds. Abrasions. Abrasions are made when the skin is rubbed or scraped off. Rope burns, floor burns, and skinned knees or elbows are common examples of abrasions. This kind of wound can become infected quite easily, because dirt and germs are usually embedded in the tissues. Contusion. This wound is normally caused by a blunt object, which bruises the surrounding tissues, and could cause a fracture. Bite wound. This wound is normally caused by animal bites, for example, dog, cat. Try to keep the animal that caused the bite for further tests. Ballistic wounds. A bullet or a projectile caused this wound. Damage normally caused internally. Avulsions. An avulsion is the tearing away of tissue from a body part. Bleeding is usually heavy. In certain situations, the torn tissue may be surgically reattached. It can be saved for medical evaluation by wrapping it in a sterile dressing, and placing it in a cool container, and rushing it, along with the victim, to a medical facility. Do not allow the avulsed portion to freeze, and do not immerse it in water or saline. First aid for life-threatening bleeding, including amputations. Bleeding from a wound is considered life-threatening if the flow of blood is continuous, and if the volume of blood loss appears large. A manufactured tourniquet should be used first for life-threatening extremity bleeding, and should be placed as soon as possible after the injury. A self-made tourniquet can be used if a manufactured tourniquet is not available. Tourniquets can be improvised from sticks, pipes, and triangular bandages, taking care not to use any thin cloth, or materials like shoelaces, as these can cut through the skin when tightened. Tourniquets are applied 10 centimeters above the injury, at least 5 centimeters in width, and not removed until the patient arrives at the hospital. It is important to record the time of placing the tourniquet, and informing the emergency personnel, or doctor of the tourniquet that has been placed. Do not cover the tourniquet with any bandages, or clothing to make it easily visible to the emergency personnel, and doctors. If a tourniquet is not available, or not controlling the bleeding, direct pressure, with the adjunctive use of a hemostatic dressing, if available, should be used to treat life-threatening bleeding. Hemostatic agents such as Celox and Quick Clot are designed to promote rapid blood coagulation, in the event of a traumatic wound involving an arterial bleed. Training should be done on hemostatic dressings, before they are used by the first aider. Wounds with life-threatening bleeding located on a body part, that is not on the arms or legs, such as the head, neck, chest, abdomen, shoulders, or hips, cannot be stopped with a tourniquet. Tourniquets are also not applied over a joint. These life-threatening wounds are packed with materials like gauze, or any other clothing. Packing the wound means to take the material, and place it tightly into the wound. You then apply direct pressure, and a compression dressing. Treatment for amputations. After bleeding is controlled as mentioned. Collect amputated part, keep dry, do not wash or clean. Seal the amputated part in a plastic bag, or wrap in waterproof material. Place in iced water, do not allow the amputated part to come in direct contact with ice. Freezing will kill tissue. Ensure the amputated part goes to the hospital with the patient. Often the part can be reattached using microsurgery. If bleeding occurs through the existing dressing, place a second dressing over the first, leaving the existing dressing in place. Maintain direct pressure over the bleeding area as much as possible. Avoid disturbing the bandage or pad once the bleeding has been controlled. Wounds can be cleaned with clean water or a saline solution.
My name is Av Rios, and I'm a paramedic with Lansing Mercy Ambulance on behalf of Expert Village. In this clip, we're going to go over tourniquet use to help control blood loss. Tourniquets should be used only as a last resort for blood loss control. A tourniquet should only be applied once you've came to the conclusion that you are not able to control the blood loss with direct pressure, elevation, and pressure point combined. Once you realize that that is not controlling the blood loss, what you're saying to yourself is, I'm now going to put a tourniquet on. This tourniquet is going to cut off complete blood flow to the extremity. You're going to, by lacking the extremity from getting the blood flow it needs, it's going to actually start to die and tissue necrosis will begin. What that means is by putting on the tourniquet, you're saving the person's life from the blood loss, but you're sacrificing that limb, and it should have to be amputated if put on correctly. This is an example of a commercial product that you can buy. Anything can be used similar to this, such as a piece of clothing or belt. Once you've opened this from the package, you will have the triangular bandage. What this is very similar to is a bandana. I'm not going to open it all the way up because for the sake of this, I want it to look just like this. What you want to have is approximately 2 inches wide of material. You always want to go approximately 2 inches above the injury site also. For the sake of this example, we're going to say that I am losing blood from just above my knee here. It is an arterial bleed, which means it is bright red squirting blood. I've been unable to control it with direct pressure and elevation of my leg, and by pushing on my femoral artery right here, I was still not able to control the blood loss. I then move into my tourniquet. It's important to remember the 2x2 rule. If this is my injury site, you want to go 2 inches above the injury site, and you want to go have a material to use your tourniquet approximately 2 inches wide. So what you want to do is put it right above the injury site. You then want to make sure that this is extremely tight and come up to the top and make a small knot and try to get that as tight as you can. You're not able to actually pull this tight enough to completely occlude the blood flow. It's very important that this is extremely tight, because if you only put it on partially, what you're going to do is squeeze the blood vessels, which is still going to have blood flow and going to cause the bleeding, but it's actually going to increase blood flow because the body's going to think that it's having a lack of the blood, so it's going to try to increase the blood flow to that injury site. So it's very important that if you decide to put on a tourniquet, you're going to completely occlude all blood flow to the extremity distal of that spot. Next, you want to use something. I'm going to use a pencil for this. You can use a pen, anything long, a little bit hard. You can even use a stick. Just set it right over the injury site. What you're then going to do is just wrap the ends around like this. And give it another tie here. This is just tying it in place. What you're now going to do is start to actually spin it around. As you spin it, it's going to tighten here. I'm going to stop it here for the sake of I don't want to cut the blood flow off completely to my leg. But that'll be sufficient enough. Once you have it as tight as you think you can go, or to the breaking point of whatever object you use, what you then want to do is secure it in place. If I let this go, it'll start to spin itself around again and release. So what I want to do is lock it in place. I do this by taking my 2 ends that I have left and wrapping it around and then tying itself back together again. Keep in mind it's going to release just a little bit, but it should stay in place.
Closed wound. A closed wound occurs under the skin. The tissue under the skin has been damaged and internal bleeding exists. A cold compress, for example, ice pack covered in a cloth, must be put onto the injured part to control blood circulation. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Examples of closed wounds are muscle strains and joint sprains. Cuts. Cuts or open wounds are a result of damage to the tissue, which causes slight or severe bleeding depending on the degree of the injury and the rate of blood lost. Common symptoms. The following symptoms would be present: restlessness and anxiety, progress of shock, pale, cold, and clammy skin, rapid pulse becoming weaker, faintness and dizziness, and shallow breathing, yawning, gasping for air. Treatment: wash your hands. Press the wound with thumb and fingers, holding cut edges together if necessary, until bleeding stops. Rinse wound under a tap if it is dirty. Then, using gauze, gently clean with soap and water. Work from the center of the wound outwards, using a clean swab for each wipe. Finish with some diluted antiseptic. Pat skin thoroughly dry. Carefully remove any small pieces of glass or gravel from the wound with a clean piece of gauze tweezers. For small cuts and grazes, a plaster is enough. Larger injuries need a non-adhesive dressing, secured with a gauze bandage, which you tie firmly, but not so tightly that the circulation is restricted. Never put fluffy dressings like cotton wool next to the wound. They will stick to it, and it will be painful when it comes to pulling it off. Only handle the very edges of a dressing. Nosebleeds. A nosebleed occurs when blood vessels inside the nose break. Because they are delicate, this can happen easily. Treatment for nosebleeds: let the casualty sit down. Do not let the casualty tilt their head backwards. Do not plug the nose. Advise the casualty to breathe through the mouth, and to pinch the soft part of the nose. Tell the casualty not to swallow any blood, but to spit it out, because it may cause nausea and vomiting. Press an ice pack against the bridge. After ±10 minutes, leave the nose to see if the bleeding has stopped. If not, repeat treatment for another 10 minutes. If the bleeding has stopped, tell the casualty to avoid exertion and not to blow their nose. If the bleeding has stopped, keep the head forward, and clean the casualty's face. What not to do? Tilt your head back. The injured person may swallow blood, and potentially some could go in their lungs. The patient may also start to vomit, as the blood will irritate the stomach. When to seek medical attention? Call the doctor if you cannot stop the bleeding after 30 minutes. If the nosebleed happens without a reason, or if the bleeding accompanies a headache, dizziness, ringing in the ears, or vision problems. Bleeding from the ear. Treatment for bleeding from the ear: put the casualty in a half-sitting position with the head towards the injured side, so that any fluid can drain from the ear. Do not plug the ear. Cover the ear with a sterile dressing. Check pulse and breathing rate. Treat for shock. If the casualty becomes unconscious, but is still breathing normally, put him in the recovery position. If breathing and heartbeat stops, begin resuscitation and seek medical help. Bleeding scalp. First aid for a bleeding scalp. Control the bleeding using direct pressure. If the casualty is conscious, lay them down, with the head and shoulders slightly raised. Check casualty's vital signs at 10-minute intervals. If the casualty becomes unconscious, place them in the recovery position. If breathing and heartbeat stops, begin resuscitation. Transport to hospital. Choking or blocked airways. Choking adults. Sometimes food can obstruct the airway of a person while talking when he or she is eating. Common symptoms. When this happens, a person will clutch his or her throat with both hands. He or she is making the universal sign for choking. If the person can cough or talk, encourage him or her to continue coughing. But once the patient can no longer talk or cough, you must clear the obstructed airway. Children and infants start to cry, and a color change to blue appears. Treatment. To clear the obstructed airway that causes choking, you must perform abdominal thrust by doing the following. Ask, "Are you choking?" The person will indicate that he or she is choking. If the person can talk, breathe, or cough, just encourage coughing. When the person cannot cough and is still choking, do the following. Stand or kneel behind the person and grab your fist just above the person's navel. Perform up to 5 rapid inward and upward abdominal thrusts. Repeat abdominal thrusts until the object is dislodged or the person becomes unconscious. If the person is markedly obese or in late pregnancy, do up to 5 rapid chest thrusts instead of abdominal thrusts. Repeat chest thrusts until the object is dislodged or the person becomes unconscious. If the person becomes unconscious, start CPR. If you see an object in the mouth, carefully remove it with a finger sweep. Choking children. If the child can cough or talk, encourage him or her to continue coughing. If the child cannot cough or talk, ask if he or she is choking. Perform abdominal thrusts. Stand behind the patient, Wrap your arms around his or her waist, and make a fist with one hand. Place the thumb side of the fist against the child's abdomen, above the belly button yet far below the tip of the breastbone. Put your other hand over the fist, and give 5 quick upward thrusts, into the patient's abdomen. Follow up with 5 back slaps. Continue giving thrusts, until the airway is cleared and the child begins to breathe, or until the child becomes unconscious. If the child becomes unconscious, start CPR. Choking infant. Give 5 back blows and 5 chest thrusts. Place the infant face up on your forearm. Put your other arm on top of the infant. Use your thumb and fingers to hold the infant's jaw, sandwiching the infant between your forearms. Turn the infant over, face down on your forearm. Place your arm down on your thigh, being sure that the infant's head is lower than his or her chest. Using the heel of your hand, give 5 back blows between the infant's shoulder blades. Be sure to hold the infant's jaw with your thumb and fingers to stabilize his or her head. You must turn the infant back over to give chest thrusts. Place your free hand and forearm across the infant, sandwiching it between your forearms and supporting his or her head. Turn the infant over onto his or her back and place your arm down on your thigh, making sure the infant's head is lower than his or her chest. Imagine a line across the infant's chest between the nipples. Place your ring finger on the infant's breastbone just below the imaginary line. Place the pads of the next 2 fingers just under the line. Raise your ring finger, and if you can feel the notch at the tip of the infant's breastbone, move your fingers up a little bit. Compress the infant's breastbone 4 cm with the pads of your fingers and then let the breastbone return to its normal position. Give 5 compressions. Continue giving back blows and chest thrusts until the infant can breathe or cough. If the infant becomes unconscious, begin with CPR immediately.
I'm now going to demonstrate how we do choking on an infant. This is how we support the head. Put the baby head down and give 5 back slaps. 1, 2, 3, 4, 5. Turn baby around, always supporting the head. Check inside the mouth, nothing inside the mouth. Give 5 chest thrusts exactly there where you will do CPR. 1, 2, 3, 4, 5. Check inside the mouth, nothing inside the mouth. 1, 2, 3, 4, 5. Turn baby around. Check inside the mouth. Nothing. 1, 2, 3, 4, 5. If I do see something in the mouth, put baby in a recovery position and we finger sweep it out.
Rescue breathing or artificial resuscitation. A person can stop breathing for many reasons, for example, sudden illness, allergy, and a serious accident. When a person is not breathing, but still has a pulse, it is crucial that you perform rescue breathing, which in effect is breathing for the unconscious person. When a person stops breathing, there is only a few minutes that pass before brain damage and death occurs. In a child, this time frame is even shorter. In fact, it is recommended that you give an unconscious, not breathing child rescue breaths for a minute, before you even call emergency services. Only stop giving rescue breaths if the patient begins to breathe on his or her own. The patient has no pulse, begin CPR immediately. More advanced medical personnel take over. You are too exhausted to continue. Rescue breathing is the act of breathing for a person who is not breathing yet has a pulse. You should never perform rescue breathing on a stranger, unless you have a barrier device, so that you will not catch any contagious disease the patient is carrying. Should an adult, child or infant's pulse return but is not breathing effectively, assist with rescue breaths. Rescue breaths are given to adults by delivering 1 breath every 6 seconds, children, and infants by delivering 1 breath every 2 to 3 seconds. Assessing the patient. Without moving the injured, the first aider places his hands on the patient's chest to feel for breathing and looks at the patient's chest for chest movement. This is done for not less than 10 seconds. Positioning the patient. If the patient is crumpled up, or lying face down, he is not able to be treated or helped. You must position him on his back, on a hard surface. You must exercise great care in turning him over, as he might have broken bones or other injuries. For example, spinal injuries. Head tilt and chin lift. Place 1 hand on the forehead of the patient, and 2 fingers of the other hand under the chin. Tilt the head backwards, and lift the chin at the same time, thus opening the airway. Jaw thrust. The jaw thrust technique is the safest approach to opening the airway of a victim who has a suspected neck injury. This can be accomplished by the rescuer grasping the angles of the victim's lower jaw, and lifting with both hands, one on each side, displacing the mandible forward, while tilting the head backwards. The rescuer's elbows should rest on the surface on which the victim is lying. If the lips close, the lower lip can be retracted with the thumb. If mouth-to-mouth breathing is necessary, close the nostrils by placing your cheek tightly against them. The head can be carefully supported without tilting it backwards, or turning it from side to side. Breathing difficulty or breathlessness. Breathing difficulty involves a sensation of difficult, or uncomfortable breathing, or a feeling of not getting enough air. Wheezing is one form of breathing difficulty. Shortness of breath or breathing difficulty has many different causes, including a blockage in the airway, medical conditions, as well as high altitudes, to name a few. In some circumstances, a small degree of breathing difficulty may be normal. Severe nasal congestion and being unfit are two examples. If difficulty breathing is new, or is getting worse, this may indicate a serious problem. Though many causes are harmless and easily corrected, any breathing difficulty requires that you contact your healthcare provider. Breathing difficulties can be described in several different ways. You may be short of breath, unable to take a deep breath, gasping for air, or feel like you are not getting enough air. If you are having difficulty breathing, it is almost always a medical emergency, other than feeling slightly winded from normal activity like exercise or climbing a hill. Signs and symptoms of breathlessness: bluish lips, fingers, and fingernails. Chest moving in an unusual way as the person breathes. This may indicate an airway or chest injury. Chest pain, which could be a heart attack or injury. Sharp chest pain could be pulmonary embolism or collapsed lung. Confusion, lightheadedness, weakness, or sleepiness. Cough. If the person also has phlegm or sputum, this may be pneumonia, a barking cough in a child as croup. Fever. And gurgling, wheezing, or whistling sounds. First aid treatment for breathlessness. Call the emergency services. Check the person's airway, breathing, and circulation. If necessary, begin CPR and first aid for bleeding. Loosen any tight clothing. Help the person use any prescribed medication, such as an asthma inhaler or home oxygen. Continue to monitor the person's breathing and circulation until medical help arrives. Do not assume that the person's condition is improving if you can no longer hear wheezing. If there are open wounds in the neck or chest, they must be closed immediately, especially if air bubbles appear in the wound. Bandage such wounds at once. A sucking chest wound allows air to enter the person's chest cavity with each breath. This can cause a collapsed lung. Bandage the wound with plastic wrap, a plastic bag, or gauze pads covered with petroleum jelly, sealing it except for one corner. This allows trapped air to escape from the chest but prevents air from entering the chest through the wound. Do not give the person any foods or drinks. Do not move the person if there has been a chest or airway injury unless it is absolutely necessary. Do not place a pillow under the person's head if he or she is lying down. This can close the airway. Do not wait to see if the person's condition improves before getting medical help. Get help immediately. The EpiPen. Everybody with severe allergy should be aware of the possibility of AS, a potentially life-threatening reaction that impairs breathing, causing a sudden drop in blood pressure, and can send a body into shock. For that reason, most people with severe allergies are prescribed epinephrine, also known as adrenaline, administered with an auto-injector as soon as symptoms develop. In South Africa it is available as an EpiPen. The EpiPen must be given as soon as you see that the patient has breathing problems due to an allergic reaction. Only the patient's own EpiPen must be given. If no EpiPen is available, call the ambulance services immediately, or get the patient to a hospital immediately. Most people that experience breathing problems due to allergic reactions should carry an EpiPen with them. Triage. Triage principles refer to prioritization of patients for medical treatment. In other words, it means the process of prioritizing sick or injured people for treatment according to the seriousness of the condition or injury. Triage is the medical screening of patients according to their need for treatment and the resources available. It applies to mass casualty situations, when conventional standards of medical care cannot be delivered to all victims. The treatment must be consistent for all casualties, and the condition must be monitored and treated accordingly. Sorting of patients on a scene. In adults, priority for treatment is based on rapid assessment of level of consciousness and vital signs. As a first aider, you will assess the victims one by one and identify vital signs to give you an indication of the degree of urgency for treatment. You will then prioritize the urgency, according to the level of seriousness of the injured person. The first aider should distinguish between injured patients that walk or sit and patients that are lying down. The first aider should assess continuously while sorting the patients and delegate tasks to other. That way he can determine if a person's condition deteriorates. The injured person will then be moved to another, or higher group. Group 1 to 4. Group 1, these injured persons have life-threatening injuries such as cardiac arrest, respiratory problems, serious bleeding, amputations, open chest injuries, serious head injuries, and should get immediate attention. Group 2, these injured persons have serious but not life-threatening injuries, for example, head injuries, multiple or large fractures, neck and spinal injuries. Group 3, the injured persons have light injuries, for example, burns, small fractures, wounds, and shock, but do not need immediate attention. Group 4, these persons are deceased. The scene. Location of emergency, for example, residential or rural areas. Exact address, or landmarks and crossroads. Location of the victim, for example, trapped in vehicle. Associated complications that will need special equipment. Plan. Whom to call for help? What to say?